CTD ILDs. So the diseases, the connective tissue diseases that we see and we see associated with interstitial lung disease are your rheumatoid arthritis, systemic sclerosis, systemic lupus erythematosus, mixed connective tissue disease, polymyositis, dermatomyositis, and Sjogren's syndrome. Now, the key pulmonary and extrapulmonary manifestations of CTD ILD, when you look at the manifestations per se, we have been talking about the findings. So we know that the pulmonary findings that we look at when we look at a CT chest, we see ground glass opacities, reticulation, traction bronchiectasis, honeycombing, and even consolidation in a few cases. The common patterns that we see is your UIP pattern, NSIP pattern, organizing pneumonia, LIP, and then the DAD pattern. Then extrapulmonary manifestations include your vasculitis, which is commonly seen in rheumatoid arthritis and SLE, and pulmonary arterial hypertension, which is most commonly seen in systemic sclerosis. Now, there are various patterns. Like I said, I mentioned about the pulmonary manifestations and the patterns that are associated. We are going to be discussing and understanding these patterns again today and then look at the individual connective tissue disease related ILD. So we have the NSIP, the UIP pattern, organizing pneumonia, LIP. We even also see diffuse alveolar hemorrhage, sometimes even non-specific ground glass, and then DIP in a few cases. So let's understand again, rather revise the usual interstitial pneumonia pattern. In CTD, ILD is frequently associated with RAILD. You see interlobular septal thickening. Now, if you remember the fibrotic ILDs, we know fibrotic ILDs have honeycombing, they have reticular shadows, and traction bronchiectasis. So again, to remember the UIP pattern, because we are going to be repeating these patterns again and again, it has the subpleural and basal predominance. Honeycombing is mandatory with or without traction bronchiectasis or bronchiectasis. Then ground glass opacities are usually absent, and you need to rule out, exclude other causes. So UIP pattern has these typical features. Then when you look at the connective tissue disease related UIP and the IPF related UIP, the CTD UIP is more commonly seen in younger individuals, 60 years, and IPF UIPs in older individuals. And exuberant honeycombing, which is very characteristic of CTD related UIP pattern, I'm going to be showing you this as we go ahead, is very characteristically seen in connective tissue disease related UIP, whereas in IPF UIP, it will be subpleural basal, like I just talked about the UIP pattern. Then when we look at the NSIP pattern, it is particularly seen in younger females assessed for underlying autoimmune disease. I'm talking this in relation to connective tissue diseases, okay? Then frequently seen in systemic sclerosis, there is subpleural sparing, spatial and temporal homogeneity. In the early phases of the disease, there would be predominantly ground glass opacities that you would see in your NSIP pattern. And in later phases, you would see inter and intralobular septal thickening as well as traction bronchiectasis, bronchiectasis. And it can also, basically it represents your increasing fibrosis. Now, this is a characteristic cellular NSIP. As you can see the early form. There is diffuse ground glass with reticulation seen in bilateral lung fields on this axial cut. Then fibrotic, you would have uh, extensive fibrosis. You would have traction bronchiectasis, bronchiectasis as well. Then this was a patient basically of polymyositis, but had an NSIP pattern. You can see there is some subpleural involvement here. You can see there is presence of ground glassing. There's presence of reticulation. There's even presence of some traction bronchiectasis over here. Then we've talked about the UIP pattern. We've talked about the NSIP pattern. Let's also look at the organizing pneumonias. So these would have peripheral and bronchocentric consolidation. So right now I'm just emphasizing on the patterns and their association, how we see them in connective tissue diseases. Now, this is a case of fibrotic organizing pneumonia with peribronchovascular fibrotic pattern, as you can see on the axial cut. Now, when you per se look at the connective tissue diseases and you look at the HRCT findings, most common would be NSIP. And NSIP is seen, as you can see on this slide as well, systemic sclerosis, mixed connective tissue disease, polymyositis, dermatomyositis, as well as in Sjogren. Now, UIP you often see in rheumatoid arthritis, right? And diffuse alveolar disease, serositis, or other findings that you can see in SLE and LIP in Sjogren. Now, there are certain signs. We've talked about patterns, we've talked about specific patterns related to the specific connective tissue diseases that we are going to be talking about today, rather recapping. And let's also understand that there are certain signs that when you look at them on a CT scan, you are, automatically you think of connective tissue disease related ILD. So there are certain ILD signs that you would see on HRCT chest of a patient, and they are very specific for diagnosis of connective tissue disease related ILD, like your exuberant honeycombing. Now, this is presence of extensive honeycomb and cyst formation within the lungs. More than 70% of your fibrotic lung is covered. As you can see, there is exuberant honeycombing. Bilaterally, there are extensive cysts and honeycomb-like formation in both the lung fields. Again, this is another exuberant honeycomb sign, another presentation from a different patient. So this is one of the signs when you see you are made to think of your patient having connective tissue disease related ILD. Then straight edge sign. Straight edge sign is another sign wherein as you can see there is fibrosis isolated to the lung basis, and there's a sharp demarcation. So the lower lobes are involved, the upper lobes are spared, and this has the highest specificity for CTD related UIP, and it is seen in a lot of your rheumatoid arthritis patients as well, seen in other connective tissue diseases as well. But then this has very high specificity for connective tissue diseases per se. Then anterior upper lobe sign, which is predominance of fibrosis in the anterior aspect of the upper lobes, extending from the subpleural lung. So there is subpleural involvement as well, but the anterior aspect. This was a case of rheumatoid arthritis. So anterior upper lobe sign is also the third sign, which is again, very specific for your CTD ILDs. Island-like fibrosis seen in cases of SLE, scleroderma, ILD associated with vasculopathy. So you can see here, there is presence of fibrosis in a form of an island over here. Then four corner signs. So presence of reticular opacities, ground glassing, and honeycombing in the anterior lateral regions of the upper lobes, as well as posterior regions of the lower lobes. Remember, on an axial cut of a CT, you will see in four corners presence of whether reticular opacities or ground glassing or honeycombing. So this is very specific. And again, four corner sign is your fourth sign for specific sign for connective tissue disease related ILD. So we've understood about the patterns. We've revisited the patterns, the UIP, the NSIP, organizing pneumonia. There are other patterns also like LIP. We've talked about the specific CTDs. We've talked about specific signs that are associated with the connective tissue disease and which make you think about the underlying cause of the ILD being a connective tissue disease. Now let's look at the individual diseases per se. So let's begin with rheumatoid arthritis. Now, in rheumatoid arthritis, the most common pattern that you would see is your UIP pattern, and it's seen in about 40 to 60% of cases. The next pattern that you see is NSIP, which is in about 11 to 30% of cases. They both carry bad prognosis. The other patterns that you would see would be your organizing pneumonia, acute interstitial pneumonia, and then combined pulmonary fibrosis and emphysema. Now, something about combined pulmonary fibrosis and emphysema in these patients is that 50% of the rheumatoid arthritis patients, it's seen in 50% of these RA-ILD patients, especially the ones who are smokers. So, common pattern again in RA-ILD is UIP. then NSIP, and then organizing pneumonia and AIP and the other patterns are can be seen. Combined pulmonary fibrosis and emphysema seen in, especially in smokers, in about 50% of the individuals. So this is a case of typical UIP pattern in a patient who had rheumatoid arthritis. NSIP pattern in a patient of rheumatoid arthritis, you can see ground glassing, you can see reticulations. Then again, a case of, now NSIP, you can see that there is areas of ground glassing and there are areas of normal lung. Over here, ground glassing, normal lung. So demarcated areas, and this is an NSIP pattern in a case of rheumatoid arthritis. Then we've just talked about the anterior upper lobe sign, and this was a case of rheumatoid arthritis with anterior upper lobe sign. Exuberant honeycombing in a patient of rheumatoid arthritis. Uh, Follicular and obliterative bronchiolitis is another finding that you can see in a patient of rheumatoid arthritis, wherein, in early phases when there is airway involvement and fibrosis is not there. Because of the airway involvement, there will be areas of low attenuation, as you can see over here with these arrows, if you can appreciate, So, uh, this is a presentation also seen in some cases of rheumatoid arthritis. Then nodules. Now, nodules, as you can see in these axial cuts, they are bilateral, they are subpleural also. Very rarely, it's a very rare manifestation of rheumatoid arthritis, and they rarely cavitate. This axial cut shows, because this is a patient of rheumatoid arthritis, there are other findings as well, but nodules is a very rare manifestation. Now, the next disease that we are going to talk about is systemic sclerosis. And in systemic sclerosis, the most common pattern that you see is NSIP. Like I said, NSIP is much more common. It is one of is the most common pattern of ILD, which you see in connective tissue disease related ILD patients. The second most common pattern that you would see in one third of the patient is UIP in systemic sclerosis. Then organizing pneumonia is less common. So this is a characteristic cellular NSIP. You can see ground glassing in both the bases of this patient. Typical NSIP again in a systemic sclerosis. So these patients had a diagnosed systemic sclerosis, and the axial CT cuts are showing you the NSIP pattern. There is ground glassing, there is some reticulations, there is even traction bronchiectasis over here. You can see over here, there is some traction bronchiectasis. Now, this is again a systemic sclerosis patient with NSIP, typically with ground glass. If you can appreciate, there's a lot of ground glassing in both the lung fields bilaterally. Some very minimal traction bronchiectasis, as the arrow is trying to point out, but majorly ground glass. This is a fibrotic NSIP in a systemic sclerosis patient again. Then four corner sign we've just talked about. You can see uh, the reticulations, the honeycombing, ground glassing in four corners of your axial cut, and mostly in the uh, upper lobes, the superior segments of the upper lobes and the superior segments of the lower lobes. Then in systemic sclerosis, there is an extrapulmonary manifestation. Like you see in this axial cut, when you look at this mediastinal window, there is increase in the size of the pulmonary artery more than the aorta, which is suggestive of pulmonary artery hypertension, which is an extrapulmonary manifestation, very specific to systemic sclerosis. And you can also appreciate a dilated esophagus. Again, these are the findings which are seen in patients with systemic sclerosis. So remember, there are specific patterns that we've talked about. We've talked about connective tissue diseases, and we've talked about the signs which are specific to these. And we're just looking at these signs and different patterns of specific diseases. Now, the third connective tissue disease that we're going to look at is polymyositis and dermatomyositis. Now, these are basically idiopathic inflammatory myopathies. They have different manifestations, pulmonary as well as extrapulmonary. When there's an associated rash, there's dermatomyositis. There's also something known as the antisynthetase syndrome. So this is a typical NSIP pattern in a patient with polymyositis. You can see ground glassing, you can see reticulation, you can see some subpleural involvement here in the right lower lobe. You can see some traction bronchiectasis as well. Then another case of polymyositis, dermatomyositis, and an NSIP pattern in this patient. Basically, features of organizing pneumonia and NSIP. Seen there's some organizing pneumonia over here. There's some bronchiectatic changes over here. Then this is another patient with polymyositis, dermatomyositis, and when you look at these axial and coronal cuts, you can see peripheral and bronchocentric consolidations. You can also appreciate air bronchograms over here. And in the follow-up CT, there is typical evolution of the shadows and also migration and location changing. So this is also something which has been associated with polymyositis and dermatomyositis patients. Now, atoll sign. To understand atoll sign, first let's revisit the halo sign. Now, halo sign is basically a central nodule or a consolidation surrounded by ground glass, right? Which is seen in infections like aspergillus. A reverse halo was there was something in the center with ground glass. A reverse halo is ground glass surrounded by a consolidation, right? So, atoll sign is very similar to reverse halo. As you can see over here, there is a circular consolidation. If you can appreciate this white, there's a circular consolidation surrounding the normal lung parenchyma. Now, normal lung parenchyma also in this case has some ground glassing. So this is what is atoll sign. So atoll sign is basically this. In this, you can see that there is this circular consolidation which is surrounding your normal lung parenchyma, and this normal lung parenchyma also has some ground glassing. Now, anti-MDA5, a very interesting case was discussed in detail by Dr. Deepak Talwar sir. The only thing I would like to mention over here is that these patients who have anti-MDA5 antibody positive have a very aggressive course. They present with respiratory failure. You have to treat them very aggressively to begin with, and they in this we've recently seen a case and they change over days, over hours also. Sometimes very aggressive course requires very aggressive treatment, and you have to be very quick and very prompt in the treatment of these patients. This particular variant, the anti-MDA5, these axial and coronal cuts basically show you features of diffuse alveolar damage. There is diffuse ground glassing, and there are some small consolidations also present. But this findings can suddenly progress in subsequent days, and there can be diffuse involvement across the lung field. So this variant is particularly very aggressive, and the respiratory failure is also very aggressive. So after polymyositis and dermatomyositis, let's look at the next connective tissue disease, which is the systemic lupus erythematosus. Now, in systemic lupus erythematosus, there is more of extrapulmonary involvement than pulmonary involvement. And you would often find the most common extrapulmonary being pleurisy. We would also see these patients with pleural effusion and pericardial effusions. The lung parenchyma can have varied presentations, but it's less commonly involved. So there is more of extrapulmonary involvement in patients of SLE. Now, this was an SLE patient with diffuse alveolar hemorrhage. Like you can see diffuse bilateral consolidation and ground glass opacities in the axial cuts. Again, an X-ray and a CT showing you diffuse alveolar hemorrhage in a patient with SLE. Then the anterior upper lobe sign that we just spoke about, you can see wedge-shaped fibrosis in these patients, in these axial cuts. And there's architectural distortion also present. Now, lupus pneumonitis is a diagnosis of exclusion. Okay, you will have a patient with fever, dyspnea, pleuritic chest pain. If you look at this CT, you see a pleural effusion and consolidation. So you must rule out infection if there's a specific presentation. Not in this case, but hemorrhage, maybe pulmonary edema, organizing pneumonia. You need to rule out these conditions, and then you conclude that this is a case of lupus pneumonitis. So this is another presentation of a different patient with extensive diffuse consolidation. And this was again a diagnosis of exclusion. And this patient had lupus pneumonitis. Then again, island-like areas of fibrosis and anterior upper lobe sign. We've talked about these signs. So remember these signs. They're very important for diagnosing your connective tissue disease related ILD. Again, this was a 63-year-old woman with systemic lupus erythematosus and exuberant honeycombing. So, exuberant honeycombing sign is when there's more than 70% of your fibrotic lung is, is involved with honeycombing. Then this was a 53-year-old man with systemic lupus erythematosus and had different signs of variant patterns of pulmonary fibrosis. This is heterogeneous lung destruction pattern. So you can see in the lower lobes there are cysts. There is some amount of fibrosis. Over here you can appreciate the straight edge sign. There is bases are involved and the upper lobes are spared. So this was another presentation of SLE. Then again, a 46-year-old patient with SLE with island-like fibrosis. Again, a variant of pulmonary. There is some cyst also seen here. Now, shrinking lung syndrome. You would have, this is another variant, which you see. It's a rather a complication, not a variant, and very rare complication. Now, what happens in a shrinking lung syndrome? You would have a patient with dyspnea and chest pain, and the patient would have significantly reduced lung volume. On an X-ray, you might, you would see elevated diaphragm. But on the CT scan, there will be absence of any significant lung disease. Sorry. Even on the PFT, you might find some restriction. But this is what is shrinking lung syndrome. It's one of the very rare complications seen in these patients. Now, the next connective tissue disease that we are going to look at is the Sjögren's syndrome. It is an autoimmune disease wherein you have reduced lacrimal and salivary gland function. The diagnosis, uh, it is a diagnosis for the primary, it is a diagnosis of exclusion actually, and ILD is present in about 20 to 25% of primary cases. It is also seen in rheumatoid arthritis, is secondary Sjögren is seen in some few cases of rheumatoid arthritis as well. The most common pattern again in Sjögren that you would see is NSIP. You can also see UIP, LIP organizing pneumonia in these patients. So this is again a case wherein you can see lung regions with anterior, subpleural as well as mediastinal location, and you can see there are cystic spaces in both the lung fields in these locations. Then Sjögren can have extrapulmonary manifestations like bronchiectasis, bronchiolitis, follicular or constrictive, as well as areas of air trapping. Now, this was another case of Sjögren, and if you see, there are ground glass opacities superimposed on reticular pattern, which reflects the lymphocytic infiltration, the LIP pattern, which is seen in Sjögren. And if you can also see, there are these thin-walled peribronchovascular cysts, and the nodules you can see here in subpleural and centrilobular nodules also. So this was an LIP pattern in a patient of Provin-Sjögren syndrome. Now, mixed connective tissue disease. Again, autoimmune disease. These patients have high U1-RNP antibodies. Now, there can be a combination of systemic sclerosis, rheumatoid arthritis, uh, polymyositis, and SLE. Symptoms appear over a period of time. 75% of these patients have pulmonary involvement. Commonest again is NSIP pattern, and pulmonary artery hypertension is seen in 50% of these cases. Again, a fibrosing NSIP in a patient with mixed connective tissue disease. Again, in a NSIP pattern seen in a mixed connective tissue disease patient. Now, another entity that we see is drug-induced ILD. What is drug-induced ILD? You have a patient of connective tissue disease. You've put him on these specific immunosuppressive agents, and you see that the patient has features of ILD. Now, whether these features are patient is developing it because of connective tissue disease or drug-induced, you cannot differentiate. So the only way to know this is that if you discontinue the drug and the you see a resolution in the features of ILD of that patient, then it is most likely associated with most likely it is the drug-induced ILD. And we know that we've seen this most commonly with methotrexate and cyclophosphamide. And with methotrexate, you would see this occurring within months. With cyclophosphamide, it can be from 2 weeks to 13 years. And other drugs like bleomycin, amiodarone, gold salts, and even in some cases of nitrofurantoin. Now, prognostic factors of CTD ILD on imaging. UIP pattern itself has a poor prognosis, and there is a direct correlation to the extent of fibrosis, honeycombing, as well as traction bronchiectasis. Acute exacerbations are evidenced by acute respiratory deterioration, new ground glass attenuating the alveolar abnormalities on imaging. Just to simplify and summarize in brief, rather, so we've talked about the UIP, the fibrotic NSIP, cellular NSIP, and organizing pneumonia pattern. When you see more of fibrosis, when you see more of UIP pattern, you think of rheumatoid arthritis. When you see more of cellular NSIP, then you think of scleroderma or mixed connective tissue disease. There would be a component of fibrotic NSIP also in these patients. And inflammatory myositis, as the name suggests, inflammation, more inflammatory, you would find more of organizing pneumonia. So, this is just to simplify the process of so many patterns and so many connective tissue diseases. So, more fibrosis, more UIP in rheumatoid arthritis, more inflammatory, more organizing pneumonia and inflammatory myositis, and a cellular NSIP mixed pattern in mixed connective tissue and scleroderma patients. So, just to conclude, connective tissue disease ILD, they have a spectrum of imaging patterns, which we've talked about. The various patterns, they can be overlapping. UIP pattern is most common in RA, rheumatoid arthritis, and SLE. NSIP is the hallmark of systemic sclerosis, also seen in polymyositis, dermatomyositis, Sjogren syndrome, showing subpleural sparing, ground glass opacities, and homogeneity. Organizing pneumonia and LIP are seen in antisynthetase syndrome, Sjogren, as well as your polymyositis and dermatomyositis. Always remember the unique signs: the four corner sign, the anterior upper lobe sign, straight edge sign, exuberant honeycombing, because they help you to differentiate, and they're very specific for connective tissue disease related ILD. Then HRCT plays a pivotal role in prognosis, diagnosis, as well as follow up. Fibrotic burden correlates with poor prognosis. Acute exacerbations present with new ground glass opacities, and they need urgent evaluation. Pulmonary involvement reflects the underlying systemic disease, and MRI may complement HRCT in selected cases, especially when you're looking at extrapulmonary findings. Thank you.